Everybody. On behalf of the PHRN, I'd like to welcome you to today's webinar. Today, I'm speaking to you from the University of Western Australia, whose campus is situated on Noongar land. And the Noongar people remain the spiritual and cultural custodians of their land and continue to practice their values, languages, beliefs, and knowledge. First of all, just a little bit of housekeeping. If you've got any questions for today's speakers, please type them in the Q&A box at any time during the presentation, and we'll answer as many as we can at the end of the session. The presentations are being recorded and we will make them available on our YouTube channel as soon as possible after the webinar. So let's get started. Introduction. So today with me, I've got Kate Miller, who's the Senior Specialist for Science and Partnerships from the PHRN, and also Rory Wolfe, who's the Statistical Director of the Monash University Clinical Trials question. Kate's going to answer some questions about PHRN's decision to fund a data utility comparison study, and Rory's going to talk about the study that we funded. Unfortunately, Charlie Harper, who's a data scientist from Oxford University, has been unable to join us today, but he has recorded his presentation, so we're going to play that for you as well. And if you've got any specific questions for Charlie, please forward those to us at the PHRN email address, and we'll make sure that Charlie has the opportunity to answer those questions for you. So we're going to start I'm going to ask Kate a few questions about the origins of this project for PHRN, and then we'll move on to Charlie's presentation and we'll finish up with Rory's presentation. So Kate, can I ask you a few questions? Firstly, can you tell me why the PHRN decided to commission a data utility comparison study?
Yeah, sure. So the PHRN, we receive funding through the Commonwealth Government for a body of work called TrialLink, which is really looking at how linked data can be used to better support clinical trials from planning and initial feasibility assessment all the way through to long-term follow-up. The data utility comparison study is just one initiative of this large body of work. So the focus of the DUCkS study is to really look at whether linked real-world, routinely collected administrative data can in fact be used to support the measurement of your primary and secondary endpoints in clinical trials. I think most people would consider randomized controlled trials as the gold standard for testing whether an intervention actually works. They're great for establishing cause and effect, but they can be really expensive. They can take a long time, and they can also be quite operationally complex. So we were really keen as part of the work that we were doing with TrialLink to see if there were ways in which linkage could offer a more efficient, yet importantly, comparably reliable way of measuring trial outcomes. And then I think within that, we're also really interested in what that might look like. So is the data of sufficient quality to replace trial adjudicated data during the trial, or similarly, could it be relied upon as a primary source to measure long-term outcomes to extend the length of follow-up after a trial has ended, or is it only suitable in conjunction with adjudicated trial data, for the purposes of improving completeness or reducing the amount of data that we collect from our participants, or cutting down on manual adjudication.
So what specifically were you hoping that the DUCkS study was going to achieve?
Routinely collected administrative data, so like your hospital admissions or your emergency department presentation records, they're generated as part of everyday healthcare, right? So they're collections either usually authorised or required by law, which means they do capture the whole population that uses those services. So that does give the data set a lot of potential and a lot to offer. They're already collected, so they may offer a cost-effective and efficient alternative to gathering that trial-specific data, but the data is collected as part of service delivery, and it's not collected for research purposes. And so there are uncertainties around its accuracy and its completeness and its timeliness. So the PHRN felt that it was really important for us to understand, or at least have some insight into how reliable and suitable these data really are before we go and encourage the use to support clinical trials. And then obviously trialists and regulators and funders will also, equally want to be really confident that the administrative data can be trusted for trial outcomes before they look to embed it in their trial as well. So I think the DUCkS studies were designed to help answer those questions and to try and build confidence.
And how's the DUCkS study going to help with that?
I think the DUCkS study just gives us a structured way to assess whether real-world data, and in our case, administrative data specifically, can replace or complement traditional trial data. I think it provides a framework that allows us to, methodically examine the administrative and utility aspects. So things like your data quality, accessibility, timeliness, costs, to determine whether administrative data can actually, truly be fit for purpose. I think one of the things that really attracted me to the DUCkS studies was that it considers data quality at different tiers, for want for a better word. So at a high level, would the treatment effect be the same regardless of what data source you use? So if I relied solely on linked administrative data, would I come to the same conclusion as if I had just used the trial adjudicated case report forms? And then you've got this other level that says, okay, are the instances of the events the same? So do they exist in both data sources equally? So is there a death record, for example, for a participant in both data sources? And then there's this other level, which is like a more detailed analysis of each record. So, what's the level of agreement of detail about that particular event? So, if we use the death record, for example, okay, yes, it exists in both, but is the date of death the same, for example? Or is the primary cause of death that's been recorded the same in both? So I think for us, what the DUCkS study helped with most was it allowed us to really pull things apart, and isolate the performance of different aspects. And I think what that does is just gives us really good insight into what it can and can't be used for, and where the data can reliably support trials, and where it isn't a good fit, or isn't appropriate or feasible. I don't think we're trying to say that it's the answer to all things. We just want to be really clear about its limitations, but also its possibilities.
So we chose to work with the Esprit trial to
We
run
did.
a DUCkS study. Why the Esprit trial?
We chose the Esprit trial for a few reasons, other than but firstly, we were looking for trials that were just really well established. And then we were also looking at trials that had already used linked data in their trial. And then secondly, the Esprit trial was really closely aligned with the Ascend trial in the UK, for which a DUCkS study had already been completed by the University of Oxford. So both trials were, they were really well aligned. They similarly examined the role of low-dose aspirin in preventing major cardiovascular events in people with established cardiovascular disease. They shared similar target populations, and also shared an interest in similar key endpoints. And the Ascend trial had done an enormous amount of groundwork in identifying, the relevant ICD codes and aligning outcomes and writing protocol. So it allowed us to piggyback almost on the work that they had done, which meant that we could avoid having to design a DUCkS study from scratch. And we were able to follow an established approach, and just then really focus Rory and his team on how we need to adapt that methodology to best suit the Esprit trial. But I think it gave us a really great start, a great head start, which is great. And then I think one of the other benefits is that we now get to compare the results between the two studies, which is something that we were really hoping to share with everyone today.
Fantastic. Well, thanks for that. I think that really sets the scene for the two presentations today. And now we're going to hopefully perform a technical feat and get this video to work first off. So
Okay.
I'm hoping.
Bear with me. I'm just going to share the. Nikki, I just need you to give me permissions to do this. Thank you.
hasn't come
Okay.
through yet. Here we go.
We're all good. Everyone can see that okay?
That's looking positive.
Great.
Fantastic. Well, thank you for inviting me to speak today. I want to say massive congratulations to Rory and the team for their wonderful work in Esprit. And with the talk that I would like to do now, I hope that I can offer a macro lens to some of the DUCkS work they've done and kind of ask the question about what next? Why does this kind of work matter? And how I'm going to present that today is going to be talking about the Ascend Plus trial. And this is a trial that I've been working on for a year and a half now, and we're still at the point of finishing off randomization. But I think that the beauty of a trial like this is it's really able to demonstrate exactly where we can use the type of results that we generate from doing data utility studies. So if we look in the UK's perspective of conducting data utility comparisons, back in 2021, 2022, we had finished conducting the Ascend trial, which was similar to Esprit, a large primary prevention aspirin trial in the UK in 15,000 people with diabetes and no prior vascular disease. Participants were randomized in a 2x2 factorial design to aspirin versus matching placebo and omega-3 fatty acids versus matching placebo, with the primary efficacy outcome being serious vascular events, which was a composite of non-fatal MI, non-fatal ischemic stroke, TIA, or vascular death excluding intracranial hemorrhage, with a mean follow-up of 7.4 years. And at the end of the trial, to be able to identify a small number of people that were lost to follow-up, we actually obtained linkage data for England, Scotland and Wales, so therefore the vast majority of participants in the Ascend trial. And what that was meant for us able to do is that we could look retrospectively at the whole of the within trial period and compare the UK electronic health records versus that of direct adjudicated follow-up. So as you'll have seen earlier today, these slides might become quite familiar for you now. So in this case, what the comparison was our adjudicated follow-up that we did within the Ascend trial versus that of our UK linkage data for hospitalizations and deaths. And what we found here is that overall for serious vascular events and its subcomponents, that we got fairly strong agreement for most components of the outcome. And this was true apart from in TIA, where what we identified is that sensitivity was only about 30%. And this was primarily because most TIAs didn't lead to hospitalization and therefore were captured in GP outpatient in a non-admission setting. If we then look at the randomized element of the trial, when we reran the randomized comparisons using the routine data follow-up, what we found is that essentially we got the same result had we used this electronic health record data compared to adjudicated direct follow-up. And importantly with this work that I think we can't underestimate is that we did the work, but then we published it. And that was really important because it gave us a lot more time to be able to do deeper analyses into it, to be able to collect it in a way that it was a rigorous report for those external to our trials unit. And then we were able to put it in the public domain to inspire others to conduct similar studies. So from the ASCEND trial, we were able to generate 3 publications validating our methodological work. Why does this matter, you might ask? Well, I think what then happened is that we were able to put theory into practice by looking at thinking about our next trial called ASCEND Plus, which is the larger sibling of ASCEND. And in this trial, which is again a primary prevention trial, unlike the previous trial that randomized people to aspirin versus placebo, in this trial, people with diabetes and no prior MI or stroke were randomized to oral semaglutide or placebo, with cardiovascular events being the primary outcome. And by the end of recruitment, we would expect to have randomized about 20,000 people with type 2 diabetes. And the difference with the ASCEND Plus trial is because we've been able to design this since having run the DUCkS studies, most of the, as I will show you, most of the elements of the trial involve some level of using administrative data, either in invitations, baseline, or follow-up. So we're able to vastly kind of streamline this trial using this data that is already being collected in a healthcare setting. So if we think about the study design of the ASCEND Plus trial, it's very, very simple. Essentially, participants who are expressing interest in the trial undertake a screening form and then enter into run-in, which is approximately 8 to 12 weeks, where they are up titrated on oral semaglutide, and we're looking here at side effects and whether they can tolerate the drug. If participants are able to get through the active run-in phase, then they're randomized either to oral semaglutide of 14 milligrams daily or matching placebo. And then they're followed up for median follow-up of 5 years, in which we have direct mail-based follow-up or online, which uses which participants complete CRFs for us in 12, 24 weeks, and 24 weekly after that. But most importantly for us, as well as the direct contact with participants, we're also relying on regular data linkage for outcomes for the trial. So one element of the trial where data linkage or administrative data was incredibly important was in identifying eligible participants. What we were able to do is through the National Health Service DigiTrials recruitment service within England, we were able to define them a set of search criteria for those who have type 2 diabetes and no prior heart attack or stroke. We were then able to apply this algorithm to the hospital episode statistics and primary care dispensing data to identify a pool of people that are eligible for the trial. Then what we were able to do is ask NHS England through a contract mailing house to send out 10,000 invitations a week to different postcodes throughout the country to be able to invite people to the trial. What people received was quite a simple letter like this, in which they had a leaflet and an invitation letter and a form. And if they completed this form and sent it back to us in Oxford, we were able to then go directly back to NHS England and be able to obtain their identifiers, and therefore be able to have the information to be able to link them and recruit them into the study if they wanted to do so. The important part of this as well is that the participant had a choice of how they'd like to be contacted, and the primary choices was between either completing the forms online or being in contact with a nurse to be able to do it over the telephone. And in fact, we've found so far that about 80% of participants have wanted to just do all the process online, while only 20% have wanted to have contact via telephone. When you go online, there are a lot of videos that we've been working hard with our PPIE team and others to be able to have them that are very understandable to participants. And as well as the videos themselves, there are some questions that we go through to make sure that people have understood the randomization process and what they're signing up for. As well as contacting and liaising with participants remotely, it's the same for the drug as well. So study treatment is mailed to participants. And as you can see, it's a box like this, where every 6 months or so, we would send the drug to the participants, blinded, of course, to semaglutide or placebo, and they would be have a box of these 6 months tablets. They'd have to take those, and the next 6 months they would receive the next batch. The other part of this trial that's incredibly important is that of the extensive data linkage for outcomes that we've been able to obtain, and this is through NHS England, our linkage through the National Health Service. And in this case, we're able to obtain quarterly data from hospitalizations, where in England it's called hospital episode statistics, death registry data, primary care dispensing data, which is around prescriptions, often from GPs, the emergency care data sets, and for biochemistry data, including HbA1c and EGFR, we have linkage to the National Diabetes Audit data as well. So the primary outcome of this trial is a composite of death from cardiovascular disease, non-fatal MI, non-fatal stroke or TIA, and coronary revascularization, in which we've called this major adverse cardiovascular events plus. How we obtain this data for the primary outcome is through three different sources. One of them is participant follow-up forms, which we will receive monthly. One of them would be through the death registry data, the civil registration of death that we receive every 3 months, and the other would be through hospitalization linkage data that we would also receive through NHS England every 3 months. And using these three sources of data together would give us the best opportunity to have the most complete ascertainment of these outcomes. And thanks to the DUCkS that I mentioned previously, we have far greater confidence that the administrative data that we're linking to can reliably identify these events. So in addition to the primary outcome, we have a vast array of tertiary and exploratory outcomes in which we plan to use administrative data to ascertain. In addition to these, because we have National Diabetes Audit data, we would also be able to look at, during the follow-up period, at people's weight over time, blood pressure, HbA1c and total cholesterol, as well as, importantly, identifying safety assessments such as serious adverse events leading to permanent discontinuation of study treatment. So, to summarize, I think if we were to ask in Australia what's next, well, I think the Ascend Plus trial is a great example of putting theory into practice. The protocol, the conduct, the invitations, the recruitment, the baseline questions, the follow-up, all had administrative data and other forms of linkage data informed into the planning of that process, but also the understanding of the strengths and limitations of this data, knowing where it was best to get this data from the NHS and where it was best to get this data directly from participants. And with the complement of those two together, so far we've been able to show that even though we're at the early stages of this trial, that we can run an efficient kind of remote trial with no physical sites, direct to participant, with linkage to healthcare data. And we hope that the Ascend Plus trial will be able to offer reliable answers on the medium and long-term effects of oral semaglutide. So that's all for me today, and thank you for listening. And I hope that for those of you in Australia, the Ascend Plus trial can really inspire you to think of how you could answer the question about what next after a spree.
In his absence, I'll say thank you very much to Charlie. We'll make sure that he knows that it was a really interesting presentation. So now we're going to move on to Rory Wolfe's presentation about the DUCkS study that he's led with the Esprit trial. So over to you, Rory. You can share your slides yourself. Yes.
Thanks, Felicity. Yep, let me just get them up.
Okay.
And to presentation mode. So I just need to get this bar out of the way. So thank you very much for the invite to talk today, and it's really nice having had a lead-in intro, and Charlie also has mentioned a little bit the context too. The question, I guess, that our study sought to address was, can cardiovascular endpoints in clinical trials be reliably captured by linkage to hospital data sets? And I'm presenting today on behalf of a big team of people. They're listed from the Esprit study with the coordinating point at Monash University. Okay, so could trials with cardiovascular disease endpoints use routinely collected administrative health data for endpoint ascertainment, even in place of traditional clinical adjudication? Our method for trying to answer that question was for CVD and bleeding events. We looked to assess agreement between events that, on the one hand, are identified by ICD-10 coding of linked administrative routine data, and on the other hand, were identified and adjudicated in the course of the Esprit study. Why would we do this? We've already really had this kind of background. Thank you, Kate and Felicity. CVD trials have traditionally used adjudicated clinical outcomes, which achieves robustness, but is resource intensive. And CVD trials often have very large sample sizes, so we need to really identify efficiencies where we can. And linkage does offer an alternative path, so a more streamlined process of data acquisition. And the question, I guess, that we wanted to address with this work is, do we get the same quality, the same accuracy? In terms of sources of data, obviously we've heard from Charlie about the experience in the UK, but can we take those learnings and how would they apply in the Australian context? So domestically, we have the National Hospital Morbidity Database here. That's compiled by AHW. It's based on electronic records for admitted patient episodes of care in public and private hospitals across the country. The data comes from each hospital's patient administrative and clinical record systems that's forwarded to state territory health authorities, typically on a monthly basis. And they then forward the data to AIHW on an annual basis. And the data is collated as a national resource in financial years ending on 30th of June. The end product then contains clinical details of each of these hospital stays, or the episodes of care, with diagnoses and procedures. We also needed to look at the National Death Index. Some of our endpoints were a combination of non-fatal and fatal events. The NDI has a record of all deaths in Australia coming from the State Territory Registrars of Births, Deaths and Marriages, contains underlying cause of death and other causes of death. The fact of death information is updated monthly. Cause of death is updated annually. And that data has been ICD-10 coded since 1997. The Esprit study, so the Esprit study started as a randomized trial in this blue period here. Participant recruitment took us a few years. We followed up, and the sort of randomization to aspirin or placebo that continued to the middle of 2017. So the trial phase of following these participants ended in the middle of 2017. We were very fortunate to receive funding from the US, which enabled us to continue following participants with the same rigor and the same sort of annual and face-to-face visit at 6 monthly phone call contacts. That continued on right up until 2024, and we actually have another grant to continue follow-up by phone for another 5 years. In terms of then trying to line up what we had done in this study with linked data, we actually have linkages quite late on in the piece. So linkages down here, sort of 2023, 2024, there is a certain amount of lag time built into the data that one receives from these resources. If you receive linked data back today, it doesn't have information up to today. It has information up to some point in the past. It might be 6 months ago, 12 months ago, 24 months ago, etc. The linkages that we received were enabled us to line up against events that we had accrued during the study, during the follow-up of our participants, all the way through to the end of June 2021. We, in the study, have, during this observational sort of follow-up phase, we had annual waves of data collection, which we called XT01, XT02, and so on. So XT02 was our kind of point in time for our curated data that we looked at in terms of events to line up against what we got back from NHMD and NDI. So, Esprit is just a convenient example of, or an illustration of a large CBD trial. The participants were over the age of 70. They were free of CBD at baseline. The primary trial question was actually whether aspirin would extend disability-free survival, but CVD was one of the main secondary endpoints pre-specified. The CVD endpoint used was a combination of non-fatal MI, fatal and non-fatal stroke, coronary heart disease, death, and heart failure endpoints, hospitalization for heart failure, death due to heart failure. With aspirin, bleeding is a particularly important side effect to be wary of. So we collected a lot of data on bleeding. In particular, we had an endpoint called clinically significant bleeding that was bleeding that led to transfusion, hospitalization, prolongation of a hospitalization, surgery, or death. And we also had an endpoint, major hemorrhage, that combined hemorrhagic stroke with that sort of clinically significant bleeding. So then our participants, we had just over 19,000 participants in total. We actually had a couple of thousand participants in the US, so we took those out of consideration. And then our Australian participants, we had a few that withdrew consent over the journey. So we sent about 16,500 for linkage. The NHMD came back, and after taking out linked episodes of care that were after our XT02 cutoff data point, we had in the end 11,873 of our participants who had at least one event in the NHMD dataset. And in total, there were nearly 60,000 episodes of care that we were able to include in analyses. We did a similar exercise in terms of counting the numbers with the National Death Index, and we ended up with 1,659 participants, where we had an NDI death included for analysis. The fact of death we had perfect agreement on between the study and the NDI, but that's because we had actually been using NDI as a part of our process of identifying deaths during the study, although our primary source of information on fact of death was from the Ryerson Index during the study. So for CVD events, we identified or defined an ICD-10 algorithm to match our endpoint definition of the trial. We borrowed heavily from the work that Charlie has mentioned, the ASCEND study. Their endpoint non-fatal serious vascular events didn't match exactly to our CVD endpoint definition, but it was close enough and contained elements that enabled us to pull out ICD-10 codes. They had used hospital admission data codes in any diagnostic position, primary, first, or second. So we were able to use their definitions with a couple of exceptions. Hospitalization for heart failure wasn't part of their endpoint, so we did some preliminary work around that, which suggested that an optimal choice would be to define that on the primary diagnostic position. And for stroke, we expanded the ICD-10 code range slightly to encompass some codes that have been used in some published US work. So I'm not going to dwell on this table. You can sort of imagine a big list of ICD-10 codes, the various parts of our CVD endpoint, the MI, the fatal, non-fatal stroke, coronary heart disease, hospitalization for heart failure. We had, as well as CVD, we had another CVD-related endpoint, major adverse cardiovascular events, or MACE, which was very similar to the CVD endpoint. It just removed some of the elements that were unlikely to be impacted by aspirin. So the MACE endpoint was defined to have an endpoint more specific to aspirin's known effects. So here then is the table of results in terms of agreement between routine data from the combination of hospital data and death index data versus adjudicated direct follow-up data from the ESPRI study. And in the various columns of this table, first of all, we've got 4 columns of numbers for each of the types of events. So the MIs, ischemic stroke, all stroke, CHD, death, hospitalization for heart failure. The first column is the count of individuals where they had an MI recorded in both sources of data. So we're laughing when we see numbers or we're happy when we see numbers in that particular column. A little bit further down, we also have a count of participants where neither source of data recorded an MI, for example. And again, we're perfectly happy with that. That represents agreement between the two sources. And that's, of course, where the majority of people sit. And that's where we get the sort of large count of people who haven't had any identified MI in terms of the first row in either source. So the question marks are the 2 columns in the middle. In routine data only, so we've found events in the hospital or the death index data that we hadn't identified as an MI, for example, in a spree. And the next column, we've got events in a spree, but they haven't shown up in the hospital or death index data. If you kind of have a quick scan down these 2 sets of columns, it's kind of interesting. We actually have similar numbers of events in each of those question mark columns. The numbers then that we've got on the right-hand end of this table are trying to summarize the agreement between the 2 data sources. So in particular, the kappa statistic is a measure of agreement. 1 would be perfect agreement. Anything above 0.6 we could call substantial. And quite pleasingly, we saw for most of these kappa statistics 0.66, 0.7, which represent substantial agreement. And it was only really hospitalization for heart failure where the agreement was not as strong. If one likes to think of things in terms of sensitivity, so this is the proportion of our Esprit adjudicated events that have been detected in the routine administrative data. We're seeing, something around 70 up to nearly 80% sensitivity. And very high specificity, but of course that's driven by this large number of people who don't have an event at all. We did then take a closer look at the disagreements. Why were we finding some cases in routine data that we didn't have identified as a case in Esprit and vice versa? Now, we looked at each of these types of event separately. So what I've got here is a kind of a summary across all of those 5 different investigations. So if we had an event that we identified in routine data only, we looked to see, well, what happened for that person at that time according to our Esprit data. And in the majority of cases, we did have for that person at that time an event. However, when it went through the adjudication process, the clinical adjudicators determined that it wasn't an event that met the requirements for the study's definition of the endpoint. So kind of ruled out on a technicality, if you like. And for a substantial number, that process was ruled out a step earlier before even reaching the adjudicators. Then for some other cases, there was in Esprit an event identified at the same date, but it was a different type of event. And in particular, that was the case for all of the coronary heart disease deaths. So what happened in Esprit for those was we might have seen it in the NDI as a CHD death, but in Esprit we had attributed the cause of death to some other cause. And then there's a mix of other reasons. There is in orange here also some cases that were identified in the linked data that in Esprit we didn't have any corresponding health event at that time for that person. And so that's the gaps potentially that this linked data is filling. In some cases, it's because participants had reduced the amount of contact that they had with the study. On the flip side, when we looked at events that turned up in Esprit, we asked the question, well, why aren't we seeing them in the linked data? For a certain proportion, and it did vary a bit by the event type, there was some there that had, at the same date, they did have a hospitalization or a death, but it was for some other reason rather than the event type in Esprit. And that was an explanation for all of the CHD deaths that we had identified in Esprit that we weren't seeing in the linked data. So they, in the linked data, would turn up as some other cause of death. It's pretty well known that I guess NDI cause of death isn't absolutely perfect. There are some issues with it. So there shouldn't be too much surprise at this on the death side that there's some disagreement on cause of death. It's a fantastic resource for fact of death. Then we had quite a substantial proportion of cases where on the same day we didn't see anything in the linked data. We didn't see a hospitalization, but within 90 days there was a hospitalization for some other cause. So we sort of wondered whether maybe those are yeah, we're left, I guess, scratching our heads a little bit as to what happened there. And then for substantial numbers, there was no hospitalization records at all. So again, we wonder where those hospitalization records would have gone. We reanalyzed the clinical trial using linked data for the endpoints to see how that would line up against the original analysis of the trial based on adjudicated endpoints. So we have little red diamonds here for the findings that were originally published, and we've added the black dots from analyses based purely on endpoints defined by the linked routine data, NHMD and NDI. And what we see by and large is a bit like Charlie had seen with Ascend. The two sources of endpoint definitions ended up with analyses and results that were fairly comparable. We got a little bit interested that for the MACE endpoint, the original analysis had a hazard ratio of 0.89, a confidence interval that crossed 1. So we hadn't made much of a story of that. With the linked data, the hazard ratio is 0.83, so a slightly stronger signal and a confidence interval that excludes 1. So that potentially would have led us to make a slightly stronger statement in the reporting of the trial. So we did this for bleeding, and I'm just going to cover that really, really quickly. Again, same sort of process. We looked at the definitions from Ascend. For bleeding, there's a little bit more consideration. There's what diagnostic position, but also in the case of, I guess, gastrointestinal and other bleeding, also looking to see just a hospital stay of greater than a night or more. So we did that same definition or requirement on the hospitalization data to identify bleeding events. Again, a whole list of ICD-10 codes separated by intracranial hemorrhage, GI bleeding, and other bleeding. And very quickly, the table of agreement, if we look down the right-hand end this time, we're seeing kappa values below that 0.6 level. So we're not seeing substantial agreement now. We're seeing sort of lesser agreement. And as we kind of go down the list, the agreement sort of tails off as we go down through these 3 different types of bleeding. And that might lead us to question whether for bleeding, where the linked data sort of fits, we would need to interrogate it more. We reran the analyses again for the bleeding endpoints with the linked data, and despite the agreement not being as good as we might have hoped it would be, in fact, the resulting analyses and conclusions that one might draw were very little changed by basing them on linked data rather than original trial adjudicated endpoints. So we still see a strong signal of harm with aspirin in terms of major hemorrhage, whether we do it based on either source of data. So the conclusions then, the degree of agreement that we saw with this Australian example was slightly below the level of agreement that had been seen in Ascend. There are some reasons that may explain that. In the Ascend study, their adjudication process did incorporate a little bit more the use of ICD-10 coding in the endpoint definition. They also took an approach to adjudication such that if events didn't have enough documentation to determine whether or not it was endpoint, they erred on the side of, well, if there wasn't documentation to refute a self-report, then they would accept that as an endpoint. The respective accuracy of CVD and bleeding endpoints, so better agreement with CVD than for bleeding, that was the same in ASPREE as it had been for ASCEND. And in general, I guess what we saw was less accuracy for outcomes with poorly defined coding structures, such as major bleeding, but also hospitalization for heart failure in our instance, and Charlie had mentioned transient ischemic attacks in their work. We can, though, be confident that the limitations around agreement that we're seeing, that those are not due to limitations with the process of linkage. We're seeing when we drilled down into the disagreements between the two sources, we're actually seeing reassuring sort of results that suggest that the process of the linkage was actually very strong, and we weren't missing too much in terms of individuals because of issues with confusion about spelling of people's names and that sort of thing that might otherwise cause trouble with linkages. The decision then about use of linkage to accrue endpoints for CVD trials involves a range of considerations, and we've sought to address the question of accuracy, but that's only the starting point. And there's also questions around the cost, the timeliness, and the resourcing that we're hoping to address in some further work. And it was interesting, I guess, a comment to reflect on what Charlie's presented. What with their Ascend Plus study, what they've done is they haven't sought to completely replace existing traditional approaches to identifying endpoints, but actually to supplement and combine both self-report and the process of linkage to really create a new way, I think, of defining and identifying endpoints for CVD trials. So very interesting times. And I just want to acknowledge and thank PHRN and Kate and Felicity, and I acknowledge again that this is very much a collaboration and a big team at our end who have contributed. Thank you very much.
And thank you, Rory. It's been very enjoyable to be working with you and your team. We've got a few minutes left, and we've got a few questions in the Q&A box. So I think let's answer some questions. So let's start with you, Rory. We've got a couple here. The first is, are some events captured in ASPREE influenced by self-report? Could this explain some of the differences between what was identified in routine data only and not in ASPREE?
ASPREE, yes, we had self-report, but we also had recruited participants through their general practice, and so we also had the general practice documentation around those participants. So I think in the case of ASPREE, probably less so. Certainly in other studies where self-report was much more the sole sort of source of accruing information, I think that would have been an issue.
And next one about your study. Does the NHMD cover all private hospitals, and could this explain differences in adjudicated outcomes versus linked data?
Yeah, that's a good question, and I don't know the precise answer to that, so I don't know if Kate or Felicity, you're able to help me out here. So I know it covers private hospitals, but does it cover absolutely all private hospitals?
Unless Kate's got a...
Well, I mean, Meteor says that it has records for admitted patient episodes from essentially all public and private hospitals in Australia. I know that there are some limitations to the private hospitals over time and across jurisdictions.
help. One of our SAEs, could you or would you recommend using linked data to identify, monitor and or confirm SAEs in a clinical trial?
Yeah, that to me is the $10 million question. And it was really interesting to see with Charlie's presentation of the Ascend Plus that they did still have the participant self-report and contact. And I don't know, it would be a question I would put to Charlie. My hunch would be that the collection of SAEs was one of the driving kind of thoughts behind needing that participant contact, especially early on in the piece of, in their case, being on semaglutide. So, I can imagine some instances where one could move wholly to linkage to provide endpoints. But there will be some other interventions where, yeah, the need for close monitoring of safety is going to be needing that participant contact.
Yeah.
Oh,
we
and
just had
yeah,
a comment, which
yeah.
is I would think the main issue with using it for SAEs is the timeliness for reporting requirements.
Yeah.
Yeah.
Yeah. So I think we've got time for one more question, and maybe both of you can answer this one. And it relates to one of the last question in the question box anyway, is essentially what's next in this space? So you alluded to some work coming up, Rory, for you. And then maybe Kate can finish up with from the PHRN perspective where we think this is going.
Yeah, so we want to, I guess, do a deeper dive with the Esprit experience in terms of the costs and the timeliness on the adjudication side of things. How much resources went into chasing up all of the documentation, putting all those documents together to present to adjudication panels, getting clinical expertise to do all this adjudication, hours and hours and hours and hours and hours. How does that stack up against linkage where, and I alluded to some of the lags in terms of data availability and that's clear to see in the questions too. How do the two experiences weigh against each other? So very interested to look at that in the Esprit context. But Kate will put that.
Kate, last word.
Yeah, so we do have a next phase to this project. So to look at the full utility of linked data, I think, data quality is obviously a really important question, but I think cost and timeframes is one that, gets discussed a lot. I think many of us assume that routinely collected data that already exists will be cheaper than child adjudicated data, but I think the onus is on us to provide evidence to support that claim. So yeah, really keen to work with Rory to explore that further. In terms of timeliness, that's obviously another critical part of utility. I think to Salma's point, there are different data collections and variables that really lend themselves, I think, to trials, and then there are some that are particularly challenging to use in a trial. Cause of death is probably a really good example of a variable that does have quite an extensive time lag of a couple of years at least. But I think that, that old expression of, don't throw the baby out with the bathwater is probably really applicable here. I think it's really important for us to be really clear about what collections and what variables are suitable, and then which ones are more challenging and shouldn't be relied upon for linkage. And then I think another aspect that we need to think about is the actual timeliness of the linkage itself. So after approvals, the time to receipt of data or the provision of data access to researchers. So I think a lot of people are aware of the often lengthy timeframes associated with data linkage. But for the most part, that's largely related to the application and approval process. The governance related to data linkage is extensive. As it should be, because we're talking about individual record level data. But for a lot of people that request, multiple linkages throughout a trial, what we hear from them is, yes, the application approval process is complex and it does take time, but once we've actually got those approvals, the actual linkage itself is happening in quite a timely fashion. So yeah, I think a really critical thing for us to do is really pull apart which parts of the linkage process do take time. And I think recognise that there's variations in jurisdictions and data collections and variables for us to consider, because it will all impact suitability. So, we do have data collections that are linked on a weekly and monthly basis. So, it is possible, but we need to explore it further. So, yeah, excited to work with Rory to look at it further.
Yes. So thank you so much, Rory. Thanks to Charlie, Harper as well, and also to Kate. And thank you for everybody who came to the webinar today. We're delighted that we could share this work with you. So we'll leave it there.
Thanks, Rory.
Thank you, everybody.
Thank you.